Thank you very much for having me at this symposium. My first opportunity to be in Hong Kong, which is really beautiful. My conflicts of interest, which have nothing to do with or little to do with the talk I will be giving today. Yesterday, I have though this disclosure. Yesterday, you had already a very nice basic course on mechanical ventilation, and my title is still a little bit in the basic field, so I hope you will not feel too many redundancies with what you heard yesterday. And again, just to set the scenario we will be discussing about for the sake of time, in the next 20 minutes, I will just focus on the situation in which the patient has no spontaneous effort because of his own reason, her own reason, or because we are giving neuromuscular blocking agents, and so we are in full control of the breathing pattern. Clearly, the things become much more complex than what I will be describing if the patient is spontaneously breathing, but again, for the sake of time, I would limit my view to this situation. So, in essence, I think it is important to understand what the ventilator is and how the ventilator works to understand the principles of mechanical ventilation. So, in essence, the ventilator is a system that delivers a flow. Whatever setting we apply on the ventilator, whatever number we change on the ventilator, the only physical entity on which the ventilator can act, and this is in the name itself, it's just the flow. Basically, the ventilators have different equipment inside, but all the ventilators do have an inspiratory branch by which they control the flow being delivered to the patient through an inspiratory valve, and during exhalation there is an expiratory valve that allows the exhalation of the gases. So, as we will see also in pressure control, when we seem to be controlling pressure, what the ventilator in fact is doing is just controlling flow. And the other entity we are dealing with is the patient, which whose respiratory system can be assimilated to a single model compartment, just to be on the easiest depiction of the system we can imagine, in which we have one pressure at the airway opening, which is the pressure measured in the ventilator, and this pressure is the sum of two pressures coming within the respiratory system. One is the resistive pressure, the pressure which the ventilator has to overcome to generate the flow and to push the flow through the endotracheal tube and the airways. And then we have an elastic pressure, which is the pressure that the respiratory system generates in response to the volume change which we are applying. So at any time, it is important to keep in mind that the pressure we read on the ventilator is just the sum of these two pressures. So, what are the modes we have available on our mechanical ventilators? To be a little bit simplistic, we basically have three main categories. We have one group of ventilations which have different names just because different ventilators call in different ways what is in fact exactly the same, just to confuse us a little bit, which is the so-called volume control ventilation, in which we set a given tidal volume. And then we have the other form of mechanical ventilation in which we set a given inspiratory pressure, pressure control ventilation. In between, we have sort of hybrid modes in which we sort of control simultaneously volume and pressure, as I will show you later on. So let's start and see how the volume control ventilation system, ventilation works. Whoops, the animation got a little bit lost. So what we will tell the ventilator is the amount of volume that it has to deliver to our patient. and the ventilator has to deliver this volume in a given amount of time, okay? So the ventilator basically knows what is the flow that it has to deliver and for how long it has to deliver this flow in order to achieve the target tidal volume. So here we have the flow that the ventilator has calculated, and the area of this flow is the tidal volume we set on our ventilator. Now, flow is now our independent variable, is the variable on which we act, and the pressure is our dependent variable. Is our readout of the respiratory system properties. Imagine we now have only resistance. Imagine we have the Y of the ventilator and we just connected an endotracheal tube, okay? And then open to atmosphere. What we will see on the ventilator screen? We will see something like this, okay? We will see a step in the airway pressure, which is the pressure necessary to push the flow through this tube, through this endotracheal tube, and then as soon as the flow goes to zero, this pressure also goes to zero because the pressure in the ventilator equilibrates back with the pressure in the atmosphere. So this is basically the resistive pressure, the pressure we are spending to generate a flow. Now, if at the end of this endotracheal tube we connect a balloon or the lungs of the patients, we will see now that the airway pressure in yellow is the sum of our resistive pressure, which is still constant because the flow is constant, plus the elastic pressure. The volume is increasing, the lungs, the respiratory system is expanding, and so the elastic recoil pressure is increasing. As soon as the inspiration goes on, we might have a moment in which the flow is zero, and so the pressure we read in the respiratory system, the so-called plateau pressure, is just the expression of the elastic recoil of the respiratory system. This is why plateau pressure is so important, so crucial, and I really hope we all measure at least once a day plateau pressure in our patients who are being ventilated, because this is the real distending pressure of the respiratory system. Now, at the same time, we can take advantage of this special moment in which the flow suddenly stops and the pressure drops from the peak inspiratory pressure, so the highest pressure that the respiratory system has seen, and the plateau. What is this pressure drop? What is the meaning of this pressure drop? The meaning of this pressure drop has to do with the resistance of the respiratory system. It is the pressure that we were spending to blow the flow through the endotracheal tube, the airways. As soon as the flow stops, we see that the pressure drops. So this is the amount of pressure we were spending to generate the flow. What I like of volume control ventilation with a square flow is that just by switching the patient in this mode for a few breaths, you immediately get a measurement of compliance, resistance, and this will will provide a very important guidance to your treatment. So just looking at peak inspiratory pressure doesn't tell you much. It tells you some information, but it is crucial to dissect the resistive aspect and the elastic aspect of the peak inspiratory pressure by measuring peak and plateau. And I would suggest to use square flow at least to obtain this measurement if you then ventilate your patient by other modes, such as, for example, pressure control. Okay, so let's move to pressure control. In pressure control, the rules do not change. The ventilator has still the same valves inside. The ventilator is exactly the same, works exactly on the same principles, except that the pressure sensors that are on the inspiratory and expiratory limb are now providing a feedback to the control circuit so that the ventilators delivers the flow which is necessary to achieve the pressure you set. It is like if you are on your car and you set up your cruise control. The cruise control will not control directly the speed of the car. It will control the amount of gas which is injected in the pistons. And here it is exactly the same. The ventilator wants to achieve a given inspiratory pressure, and to do so, it will manage the inspiratory and expiratory flows. And let's see how this works. Again, the system is exactly the same. The sum of the airway pressure is still the sum of the resistive and the elastic pressure. The difference is that now the airway pressure immediately jumps up to the desired pressure, let's say 20 centimeters of water. In order to do this, the ventilator will deliver a flow, a very high peak flow to achieve the desired inspiratory pressure. This flow will make the alveoli to expand, and so the pressure in the alveoli will increase a little bit, and the gradient between the airway and the alveoli is reduced, and so the inspiratory flow decreases and decreases and decreases because the alveolus is expanding, and so this gradient between the alveolus and the airway is decreasing. At variance from volume control ventilation, if the mechanical properties of the respiratory system change, this will lead to a change in the tidal volume, to a variation in the tidal volume. So for example, a reduction of compliance will necessarily lead to a reduction of tidal volume if we work in pressure control ventilation, and an increase in resistance might or might not lead to a change in the tidal volume according to this principle. Now this is something I'm a little bit pedantic about, but I think it's very, very crucial to understand. We only have 7 minutes left, so what do you think the answer here is? Sorry, the light is a little bit on the spot, but basically this is 30 centimeters of water, 20, 10, and 0. So this is pressure control ventilation, okay? Pressure and flow. How much do you think plateau pressure is? Do you think it's, who of you think is less than 20 centimeters of water? This is 20, okay? A? B? Who goes for B? Who goes for A? Who goes for C? Who goes for D? So I think the right answer is less than 20 centimeters of water. Why it's so? Come on, this is 20, this is flat, this is plateau pressure. But this is not plateau pressure. You see, I think this is the greatest confusion about pressure control ventilation. The fact that the pressure is flat does not mean it is plateau. Plateau pressure is the pressure measured during an inspiratory pause. And here there is no inspiratory pause. Here there is still a flow going from the ventilator to the patient. So by definition, the pressure in the alveoli cannot be the same pressure that you have in the ventilator. What you have to do, you can do in basically any ventilator, sorry, I'm going a little bit fast for the sake of time, an inspiratory hold, and this will reveal you the true inspiratory pressure. This is crucial, the true plateau pressure in pressure control. This is crucial. Yes, please take a picture. Okay, so, well, this is, again, I will go a little bit fast for the sake of time, but again, I think it's important to recall that pressure control modes are tricky. They're not easier to use than volume control modes. Pressure control is tricky. Look, for example, at the effect of inspiratory time. Here, our tidal volume is 444 ml. and our inspiratory time is 0.8. You have pressure and flow. Now we increase our inspiratory time and tidal volume goes up. Why is that? Because here the flow was not zero, so we are giving more time to the airway pressure to equilibrate with the alveoli, and so the tidal volume will go up. And if we increase inspiratory time, the tidal volume will go further up and further up and further up until we'll get to a point when tidal volume starts to go down. Why is that? Because now it's the other way around. We are trapping some gas in the alveoli. As you see here, we still have some expiratory flow. At the end of expiration, we are trapping some gas in the alveoli. And so we are generating intrinsic PEEP, and this will cause a drop in tidal volume. So it's a little bit complex, and again, I'm going a little bit fast, but just to remind you that when you're working in pressure control ventilation, there are many factors that can affect your minute ventilation. Okay, I will also skip this for the sake of time. I have a question for you now. Volume control versus pressure control. Which one is better, is more protective for the lung? Pressure control, pressure control, volume guaranteed, and it doesn't matter. Who thinks pressure control is better for the lungs? Who thinks volume control is better for the lungs? C? D? It doesn't matter? Okay, great. Why it doesn't matter? Because it's really an irrelevant question. For the same tidal volume, the driving pressure will be exactly the same, and the plateau pressure will be exactly the same no matter whether you are in volume control or in pressure control. It's exactly the same. The only real difference between these two modes is the presence of a square versus a decelerated flow. Some people, some preclinical papers suggest that this very high peak inspiratory flow that you have in pressure controlled ventilation, because it's stretching fast the alveoli, could lead to some degree of ventilator-induced lung injury, but there is no evidence in our, let's say, clinical studies that this has an impact on the patient outcome. But at the same time, there are papers that show that this decelerated flow is beneficial for those lungs that have different time constant inside, so that all the alveoli have time to equilibrate with the airway pressure. And so there are papers, this is an old paper coming from our group, suggesting that pressure control ventilation as opposed to volume control ventilation for the same minute ventilation will enable a better CO2 clearance. So and the third great difference is that, as I said, tidal volume is not guaranteed in pressure cycle modes. You can set an alarm on tidal volume and adjust your pressure limits, but there is no way that the tidal volume is guaranteed. So a way to bring together these two advantages of having a constant tidal volume, which is very important, especially if we discuss about ERDS, and a flow which has a decelerated pattern, most ventilators allow us to use the so-called auto-flow integrators or pressure control volume, pressure regulated volume control, which is a way by which, sorry, it's a little bit dark, it's very dark, but basically here, if the mechanical properties of the respiratory system change, this is volume controlled ventilation, you see that, as I described you before, plateau pressure will change. Now we switch to these hybrid modes, and basically the ventilator is working on a pressure cycled modes, but it is adapting the inspiratory pressure at every breath in order to deliver the tidal volume which we have set as our target. So, going to conclusion, I think that volume control and pressure control make a huge difference for us doctor managing the ventilator, but perhaps I think if the tidal volume is the same and minute ventilation is the same, they will lead to perhaps similar results in terms of CO2 elimination and oxygenation and ventilator-induced lung injury. Perhaps we could have hybrid modes that could share the advantages of both, so a constant tidal volume and a decelerated flow. And I would reinforce the message I gave you before, that it is crucial not just to connect the patient to the ventilator and see that peak inspiratory pressure is 28, so we think it's safe, but it is crucial to monitor plateau pressure and driving pressure and compliance to tailor the mechanical ventilation on our individual patient. And having said that, I thank you very much for your attention.